Hello and welcome. My name is Andria Tupola. I'm the representative for District 43, which starts in Maili and ends in Ewa. Today we're at Kaiser Moanalua, and I have two doctors here that are going to join us for the conversation. To my left, we have Dr. Keola Beale, who is an oncologist, and to my right, Dr. Nakatsuka, who is a long-term care physician. So why don't you start off and let us know your specialty area so that the viewers can gauge what field you work in.
Sure. So I'm a physician a long time in practice that evolved from doing a typical primary care office-based practice to one that actually involves now being able to support those with advanced illnesses and the fragile elderly within nursing homes, care homes, and homes. And therefore I do visits of patients, Kaiser patients, within the home, within care homes, and within nursing homes. But I also go beyond that and actually am involved as a palliative care physician. Palliative care is an area where those with advanced illness, and some of them that are getting towards the end of their life, really need the support beyond just what can be offered to them by drugs and other medical needs. And that's supporting someone especially to be able to know that they can be well taken care and comforted with both very good medical management of their symptoms, but also with being able to be supported emotionally, spiritually, financially, and in all these areas. And that's what I do.
Wow, that's very comprehensive. I'm sure we'll go into detail in a little bit. And Dr. Beale, your specialty area?
So I am a medical oncologist, hematologist, and I largely take care of patients who have advanced cancer, although I do also see patients with benign blood disorders. But most of my practice obviously is taking care of patients who have advanced cancer using things like chemotherapy, targeted therapy, immunotherapy, both to help patients live longer who are living with cancer, as well as helping to have patients hopefully beat their cancer and not have their cancer come back, and basically try to improve their odds of staying cancer free. But obviously I work very closely with Craig and with a lot of the palliative care services with hospice. Along with our social workers and our chaplains, we actually form a large team in helping patients transition at the end of life. And so this can be a difficult and challenging time, but it also can be a very meaningful and I think really wonderful experience in many ways for patients, I think, if it's done right and if it's done in a team setting. And so it's great to be here with Craig and obviously with you, because it's nice for us to be able to sit down and talk about these issues that come up, because I think it is really important. I think unfortunately in today's world, a lot of people die in the hospital, and a lot of people don't, I think family members, we don't get to experience what happens with our loved ones as much, I say, as maybe 100 years ago, when most of us were likely dying at home. But hopefully I think that's starting to change. I think as palliative care and hospice services are really starting to come more to the forefront, I think more people are starting to pass away at home instead of in the ICU or in the emergency room, which I think when you talk with most people, that's probably where they would want to pass away, is surrounded by loved ones and instead of being surrounded by us. And I think that it's great that we're having these conversations, because I think it's important that we as families and people out in the community all would talk about kind of what we would want at the end of life, so that way we're all clear and that we can hopefully meet the wishes of our loved ones.
So I brought them here today because I sit on the health committee at the state legislature, and there is one doctor that sits on the health committee, and I'm not sure what his specialty area is, but the majority of us are trying to do what we need to do for our constituents, represent the voice of the people, but I'm not sure if we would properly represent them if we didn't meet with experts. If we met with experts in the field that could give us some type of insight as to how we should make better decisions as lawmakers, because I'm guessing a lot of what we do affects you guys. A lot of the decisions we make in regards to healthcare, hospitals, funding, programs, all of this would again affect the way you can serve your patients. So what is the hardest part about your job?
Well, I think we have difficult discussions on a daily basis, and I think it's very challenging, especially in Hawaii, with a multi-ethnic, multicultural, multi-religious group of folks all living together on one rock in the middle of the Pacific. So it can be challenging for us to meet with these families, and there are obviously very different family dynamics going on in every family. And I think helping people to transition, especially when, in my setting, which is predominantly what I do, is trying to help people live longer, and promoting quantity of life, that eventually we get to a point where we can no longer do that. That me trying to give people, per se, more chemotherapy may actually shorten their life and not actually prolong it. We might actually make them worse instead of better. Is really helping them to switch now to saying, look, if we can't make your quantity of life longer, can we really make your quality of life better? And that's usually when we team up with folks like Craig.
Well, yeah, because the question is posed, the death with dignity bill or physician-assisted suicide bill, where there might be families that want to shorten that process. Maybe they see their loved one in pain. So how would you guys deal with that?
Yeah, the vast majority of patients and, of course, their family members don't want to die. And it may be ironic that actually I'm very cautious about having a bill coming out for allowing for physicians to be involved in assisted suicide. And it's interesting because there are polls that are out there that would allege that up to 70% of the public wants the individual to have the right to do what they want to at the end of their life, including being able to allow themselves to pass away on their own terms. But really, when it involves a physician and the surveys are then reworded to the public in terms of to then allow for physicians to be involved in a situation of suicide, then you get a very different picture. And that is because we doctors are quite uncomfortable with having to intervene as physicians when we're here as healers to do that. And so with family members and with patients, a lot of that is really reassuring them of the fears that they have. And really a lot of what applies as testimony whenever this bill for physician-assisted suicide comes up by the proponents is really this fear of how that will go. That they will be lying in a bed, strapped down, and suffering in pain and everything else, which is really undignified. And so, as Keola has said, it's trying to really show them that if they step back and are willing to plan ahead and really do take charge of their own future in their own way, that things can go so much better. There's so much out there that we can do for patients to take care of things like be concerned about pain that's unrelenting, concerned about nausea that sometimes happens with or without chemotherapy. And we have very good treatments for in which I'm certified in to take care of.
Do you see it as a possible issue if a bill like that was to pass? And if so, how so would it affect you? If there was something that gave physicians the right to terminate life, what kind of decisions would you have to go through with families, seeing as though you counsel with families about death?
Yeah, I think it's important to realize, I think these issues, at least in my experience, come up very limited. It's very rare.
Right, right. So it's not a horde of people that are asking for this, right?
Yeah, thankfully.
Yeah.
It's a very, 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 very unusual circumstances. Although I've been asked about it and people have made comments about it to me in terms of patients who are going through death and dying, fortunately it is a small proportion of patients where this, we have to have a frank discussion about these things. I think broader, bigger picture, one issue that I hope this also brings along and helps people discuss are things like advanced healthcare directives, the PULSE forms.
Right.
It's like, oh my gosh, if more people, more adults in general, whether they're healthy or sick, would just get their advanced healthcare directive, that would go, 90-something yards to getting to them where they really need to be, so their family and their loved ones really know kind of what's going to help them in terms of decisions at the end of life. Unfortunately, a lot of us just don't have those discussions, and things happen quickly, and then when they do happen, unfortunately, it can be very stressful because we as physicians are looking at family members to say, well, we can't ask your mom or your dad or your loved one what they want. We have to ask you. And like, well, we never really talked with mom or dad or loved one what they really want. So now it makes it a very difficult situation, and family members don't always agree. Mom, sister, they may say go right. Cousin, uncle, other sister may say go left.
Right.
And it puts the family in a lot of stress in terms of how to make a decision for their loved one. But I think if they would have had these conversations and if they had filled out the advanced healthcare directive, I think a lot of these things could have been, alleviated. And
So is the advanced healthcare directive like a medical will?
So yeah, basically it's a directive to say, and it is a legal document, to say that, hey, you know what, if my doctors declare that I am really not going to recover, and you guys are keeping me alive artificially, like on an intubation machine, a breathing machine, feeding tubes, these types of things, you could write on there to say, look, if doctors don't think I'm going to get better, don't prolong my life artificially with these machines. But you can also say on there that you say, look, if I can't make decisions, this is who I put in charge for me, whether it's my spouse, my loved one, and you also list alternates. Because as physicians, we make that person in charge of your medical decisions, and we can do that legally because it is a legal document. So it really makes it easier for us, because again, sometimes there can be those differences in opinions, but I think within families, if the loved one wrote that down, I think most family members would agree to respect what that loved one had put down in paper.
I think difficult discussions as a family, regarding healthcare and even regarding the end of your life is something that people need to plan ahead for.
Absolutely.
Yeah.
Right? And so a lot of times it's going to be your parents that should do it, and then you become the parents and you do it for your children. So let's talk about in-home hospice care. One of the bills that just came through was a Kupuna Care bill in regards to how many people can be in a care home. I believe it might be called a foster home. And also if a married couple can be taken care of at the same time, even if they have different health providers.
So apparently the concern on that is really that, and this gets a little complicated, that there are two types of care homes. There's the foster homes that allow for those individuals that are quite disabled, that would be equivalent to staying in a nursing home. And that would be the types of patients that a foster care home would take. And usually most of these will be Medicaid patients. I'm not totally familiar in the details. I think they allow for one private pay. And then you have these expanded arch homes that allow for those that are a little less disabled that could then age in place to come to the point of being more disabled, similar to the types of individuals that are in foster homes. And there are restrictions on that, and their concern on one hand would be, why can't we expand to have at least two private pay if it's husband and wife just stay in expanded arch homes? And I guess some of the pushback from the foster homes was that then there'd be a lot more empty beds because these are the ones that they rely on. My feeling is because of the crisis and being able to support the frail elderly and those others with advanced illnesses, that we do need whatever beds we can. So I guess feeling from the type of work that I do to support patients that are quite disabled, that the more beds we can have, the better to be able to support care.
So you said foster homes and arch homes. Are those both called rest homes, or is that a different term for a different?
Actually, they're permanent homes for the
Permanent
residents.
homes.
Yes.
Oh, I see. And those are by families can visit and see their loved ones when they're staying there, and they get specific help from nurses on a one-on-one basis?
Not necessarily. Not all the caregivers of, I think, either of these homes. I am not absolutely sure. I'm not the expert on the regulations, but I do not think that there has to be an RN at all times in the home. But there certainly have to be trained caregivers.
Would both of you deal with people that are coming from foster homes coming to you for maybe some of these treatments, as far as end of life or cancer treatments?
Yeah, I mean, I think we definitely do very regularly, because unfortunately cancer is more common in the elderly, and I think it can be challenging, especially when you're dealing with side effects from treatment, and making sure that they have the support that they need from family members, and if not family members, because unfortunately we have a growing elderly population here in Hawaii, and so a lot of times, we meet patients where they're here by themselves and all their extended family are still back in the mainland. And so they're really dealing with this alone in many ways of that word. But
in the case that they're dealing with it alone, how do you guys overcome that? They stay at the hospital, they go to a foster home?
So I think it's a mix of all of those things. I think obviously if they're acutely ill, they need to be here with us and we take care of them here. Sometimes they end up being transitioned then to like a skilled nursing facility, say that they still need more physical therapy or occupational therapy. And then from there, trying to find them placement from there. So it's usually a process, and it can be challenging. It can be very challenging to find the right place for these patients. And obviously sometimes they're not happy with where they're having to go, and it makes it very difficult. I think part of that is just because, unfortunately, not all of us have family members that are here that can be here to help us.
So let's switch the discussion into. I remember you and I had a discussion one time about the cost of medicine to prolong a day, a week, a month of life. How do you determine that?
Yeah, it's an excellent question. It's coming up more and more in oncology. The drugs that are getting FDA approved right now, some of them are really, really good. Some of these new immune checkpoint inhibitors, but some of these drugs can cost over $100,000 a year to care for a patient. And the great news, obviously, is that these drugs can work, and I do have some patients now who have been on these treatments for a couple of years, and they should have, in all reality, when you look at the type of cancer that they had, likely should have passed away already from how aggressive the type of cancer they've had. But fortunately now they're still alive, and they're still dealing with some of the side effects of the treatment, but they're living good, healthy lives, but they're having a lot of having to stay on these treatments.
Right.
And so you can imagine the cost is quite high, but at the same time, I think we as a society have to decide this whole question of kind of what the value is that we're getting out of these medications, because some of the drugs that we use are very expensive but don't really provide a whole lot of quality improvement in terms of extending life or quality of life. And so, to look at it is from a consumer standpoint, are really getting the most bang for our buck in terms of what we're doing. And these are really difficult discussions, and it's tough when you meet a patient who's having to borrow money from family members and having to do things to try and pay for their care because it's getting so expensive. I think we work very closely with our social workers. There are support groups out there, and we try and help them as much as we can. We do have a financial assistance program, so we do all these things to help them to be able to afford their care, but it is very challenging, and it's only becoming more so. And I think that that's something in our communities we're going to have to talk about in terms of how we pay.
So if someone had like $100,000 medicine or something they were taking for cancer, I mean, is that covered by insurance? Is there a portion of it?
Yeah,
Goodness.
fortunately, yeah.
Most people don't even make that much in a year.
Yeah.
How can you pay for just medicine for that?
Totally. I think that fortunately most of the drugs with both insurance, it's chemotherapy and immunotherapy, these things are covered because they're IV and they come in for an infusion. The hard part is typically with the oral chemotherapy, oral what we call targeted therapies. These are where it's more challenging because they're actually prescription drugs that you pick up at the pharmacy. And so most insurance plans, if you didn't purchase that separate prescription drug writer along with your insurance plan, then it may not be covered. And that's usually where we run into problems because all of a sudden you develop lung cancer per se, and we want to give you a drug Tarceva, which can make you live years longer. On average, patients live around 2 to 3 years, whereas without it, they would probably live less than a year. Mm-hmm. Meaningful, I think, benefit when we're talking about extending life by years, and relatively well tolerated. And so when we can give people drugs like that, it's great. The problem, though, is those drugs can cost thousands of dollars per month to be on. And if people don't have, say they weren't thinking obviously before they were going to get lung cancer and require these drugs, they don't have that drug rider on there, so then they're stuck with, oh my gosh, I have this huge bill because my insurance doesn't cover the outpatient prescription meds. And so that can be a really challenging situation. I know one of the things that's come up, in other states, I'm not sure if we in Hawaii are going to be doing that soon, is trying to get oral parity between the inpatient and outpatient prescription drugs. So that way patients can hopefully get that covered through their insurance.
But to intersect that with bills for physician-assisted suicide.
Yeah, I was going to say it plays right into it, yeah.
Because, the question comes up, of course, if for the few people that actually want to control how they die, well, why can't they? Why can't we craft a bill that has the safeguards in place in order to be sure that it's not abused, etc.? But see what Dr. Beale says, that's really whether it's going to be the patient and family that's supporting the bill or it's the institutions, the healthcare insurances that support the bill. There will always be this constant subtle pressure on cost.
Right.
And especially in a community, much of which Hawaii still remains an Asian community, I hear it almost every day from elderly Japanese or other Asians that say, I don't want to be a burden on my family, just let me go. Well, if safeguards just right now don't seem to work. There's difficulty in actually defining what terminality is. anything that actually tries to get at the patient being able to have control over the medication means that it can be done unwitnessed, and who knows what's going to go on during that unwitnessed setting. And then with all these subtle cost pressures there, I just think that it doesn't take much to change the culture of the ohana of Hawaii, where actually it becomes almost a duty to die because of the cost on either society or on the individual or rising premiums, etc. And we do everything we can to try and support families and individuals in terms of these costs, but I really think that it would be crossing the line to allow for physician-assisted suicide, because it would be so easy to go down that slippery slope towards abuse.
Well, and I'll share a small clip from a different state, but the concerns from the state that did pass that bill were that the state would fund physician-assisted suicide but not chemotherapy. And so people were getting notices that per their medical, I guess, coverage, it was going to be cheaper to just terminate life as opposed to prolong it using these therapies. And I think that's what you're referring to is the cost versus, you know, what really, and again, the culture is so fragile where it could automatically change the mindset that people need to do it because they don't want to be a financial burden on their families in a place like Hawaii that's so expensive to live in. You know, and so let's switch the conversation one last time to types of medications you prescribe, including perhaps maybe medical marijuana.
Yeah, so in Kaiser, we're a national facility, and federally it's still illegal, so we actually do not prescribe medical marijuana here. I know in the state of Hawaii, it's a little bit kind of a half law in the sense that patients can go out and get like a license. But
not from Kaiser.
But not from Kaiser. Not unless the federal government's going to allow us, because we are, a national. I mean, we have several, in several different states. So, but I have had patients go outside to people outside of Kaiser to get the license, and then they ask me if I can prescribe it, and again I have to say no, and neither can any physician in Hawaii prescribe it. And then they have to kind of go get it from Joe down the corner or whatever. So it makes it very unfortunate that for some folks, they have, I've had several patients say it helps them a lot with nausea and pain and these other issues. But at the same time, I think, it'd be great if we were doing more research to understand some of the side effects of these treatments as well, and trying to find that balance between, of course, there are going to be, with anything, there's risks involved, but for some patients, obviously for terminally ill patients, the benefits may outweigh those risks. So really, I think those kinds of discussions need to be had as well in terms of how best to proceed. But
because we may be passing a bill on including dispensaries for the state of Hawaii, regulated by the Department of Health. But they're also battling a lot of different things with those cards, giving people the ability to grow their plants and the quantities of THC that are within the plant. I mean, there's so much complication in making the right medicine because you're making it. You're not getting it from a pharmacy.
Sure.
And so a lot of other states that have legalized marijuana are seeing a lot of explosions because people do it within their own home as far as getting the oils out, extracting the THC from the plant, and different qualities of plant. And so I think, seeing as though we have legalized medical marijuana, that the push might be to get a dispensary where people can get a regulated amount. But my proposal is that we possibly roll it out sooner, but pilot it, monitor it, get input from the medical physicians, get input from the medical community and from the law enforcement community that all things are going well. And I think that both of you as doctors know that for good research, you need to kind of put a pilot out there. You need to test for side effects. And so just to wrap up our interview, is there anything else you'd like to share with the viewers in regards to health, the healthcare system, or health in Hawaii?
Well, I think our overall discussion has really been focused on, end of life and those discussions. I would encourage folks, any healthy adult really, to go out and fill out their advanced healthcare directive and make sure your physician has a copy of it. I think it's important to have these discussions as we talk about, I think, these difficult decisions that sometimes come up, and I think it's important that we know what our loved ones' wishes are and what our own wishes would be in these different situations. I think it goes a long way to helping to avoid these other discussions that come up. I think it's important that we continue to do that.
You know what? I will go do mine. I don't think I have done that, but yes, it's something I can do. Doctor, any last thoughts?
I simply echo what Dr. Beale said. That's really the focus of what we need on a broader scale, so that there's not the struggle at the end to know what that individual wants.
Well, I hope that as legislators that we can come more to doctors, come more to experts, come to their door, knock on their door, ask them for their input on things that we might be making statewide law for, things that maybe we don't understand completely. And I feel like prevention is always better, right? And so me as a state house rep, I mean, it's a 2-year elected position, and I can't change the health connector. I can't change the medical coverage for the nation, but I can encourage healthy habits in my community, encourage farmers markets, encourage bike paths, encourage activities that get families out there, and perhaps even at these health fairs talking about this medical form. Can you access that anywhere?
Yeah, actually, I'm sure we can give you some copies today.
Really?
Yeah.
So if anybody wanted one, they could get it online, or?
Yep, and there's the Pulse form as well is also available, which may be appropriate in certain situations.
I think we're going to put the link on there because it's, I may be the naive one, but I've never even heard of this. So I think that maybe everyone needs to look at this and maybe fill it out, and I can promote that in my community, most definitely. Well, thank you so much for your time, and I'll let you guys go back to healing the world.